Good morning, good afternoon, or good evening, depending on which corner of the globe you're logging in from. Thank you for joining us, and welcome to the first event in the Leading Health System Network's Safer Care Accelerator webinar series. We're very pleased to have Margaret Murphy with us today. In addition to being a world-renowned patient safety expert and advocate, Margaret is the lead external advisor for the World Health Organization's Patient for Patient Safety program, a network of 300 patient safety champions from 52 countries. The focus of her work relates to seeing adverse events as having the potential to be the catalyst for change, as well as being opportunities for learning, identifying areas for improvement, and preventing recurrences. So without further ado, I will pass the presentation over to Margaret, who will be discussing the importance of involving the patient in safer care.
What is the raison d'etre of healthcare? It is the patient in the bed, and that we come to a real understanding of what constitutes truly patient-centred care. We have become aware of the alarming statistics which describe the scale of preventable harm which occurs daily and worldwide during the delivery of care. Deaths in the US which equate to a jumbo jet crashing each week with the loss of all lives on board. Very serious stuff. It is not surprising then that patient safety has become a real focus, not only for providers, but also for patients and families who entrust our own well-being and that of our loved ones to our healthcare systems. So because of that, patient and family engagement does go to the heart of patient safety. It is no longer acceptable that the patient be a passive individual in that care process. He is present throughout the full continuum of care. He is a repository of useful information. He does have a different perspective to offer, but most importantly, he is undoubtedly the individual with the greatest vested interest in the outcome. In 2004, WHO bit that particular bullet with the launch of the World Alliance for Patient Safety. From the beginning, the role of real patients and their family givers was deemed to be a core component. Consequently, it has as one of its 6 original action areas patient and consumer involvement, patients for patient safety. And we now have over 400 patient safety champions and 52 countries are represented. Recognizing that patients and families are an untapped resource, the program accepts that taking account of the perspective of patients and their families in planning and delivering care is crucial to articulating the reality and identifying the gaps between the patient safety measures possible and the levels of safety being experienced by patients. It's necessary to ensure services are driven by patient need and are authentically patient-centred. It is also a useful validation tool in relation to the implementation of guidelines, processes, protocols, and above all, it ensures that the patient voice is heard in the global arena of healthcare. The core values of Patients for Patient Safety can be summarised in that we operate as a collective with a common aim of healthcare improvement. We are asking that the healthcare system and the individual practitioners within that system conduct the business of healthcare in a culture of safety, openness, transparency, and true professionalism, particularly in the aftermath of adverse events, thereby facilitating reporting and learning, as well as preventing recurrence. In so doing, they prove themselves worthy of the trust placed in them by vulnerable patients and concerned carers. Our goal is collaborative partnership resulting in meaningful engagement and empowerment with a deliverable of safer outcomes. And we view this as life-enhancing for all, patient, family, and clinician. Our patient role in that partnership is best articulated in the London Declaration, an output of the first Patients for Patient Safety workshop held in London in 2004, which says, "We patients for patient safety will be the voice for all people, but especially those who are now unheard." And again, in honour of those who've died and those who've been left disabled, our loved ones today, we will strive for excellence so that all people receiving healthcare are as safe as possible, as soon as possible. That is our pledge of partnership, our patient pledge of partnership. It is important to stress that we in Patients for Patient Safety are not career advocates. We are volunteers who are committed to being collaborative partners and co-producers of safe care. Circumstances have brought us to this work. For me, it was the needless death of my own 21-year-old son as a result of medical error. We have not chosen this work for ourselves. Rather, it is a responsibility which has been thrust upon us, one which we would gladly forfeit for the restoration of the lives and well-being of our loved ones who have been harmed by healthcare, albeit unintentionally. We strive to have these experiences become catalysts for change. We accept that we cannot change the past, but that past can certainly inform the present, which we can then use to influence the future. And isn't it so much better if we do that together in partnership as co-producers? That brand of partnership can be summarized as a process of empowerment of patients and families by enablers within the system. It is therefore essential that leadership recognizes and empowers patients, advocates and healthcare staffs, ensuring that those meaningful partnerships are created. And the preferred commitment says we will proactively engage patients in their own care. We will capture in every way possible the lessons to be learned from the care experiences of our raising death. And over and above that, we will embed patient and family into every aspect of our organisation's activities. We can then deliver a framework, such as that described by the Irish Commission on Patient Safety and Quality Assurance. Knowledgeable patients receiving safe and effective care from skilled professionals in appropriate environments and with assessed outcomes. And of course, we're supported in that by the report Safety First 2006, which says, around the world, healthcare organisations that are most successful in improving patient safety are those that encourage close cooperation with patients and their families. And I particularly like a very simple definition of a culture of safety put forward by Michael Leonard from Kaiser Permanente. He says, no one is ever hesitant to speak up regarding the well-being of a patient, and everyone has a high degree of confidence that their concern will be heard respectfully and be acted upon. Yes, Patients for Patient Safety has changed the lives of real people. I'm certainly a very different woman to the one I would now be had I not encountered and embraced PFPS. At an individual level, it is a very real fact that our credibility, our champions' credibility, has been strengthened in our own countries by being members of PFPS and associated with WHO. Recognised as resource persons, we are invited to represent the patient perspective in a variety of fora, and my own involvement spans the local, national and international arenas and covers the areas of policy, standard setting, education, regulation and research. And I'm truly happy to acknowledge that none of it were to come about were it not for the vision of those in healthcare who provide the opportunities and issue the invitations. And was it not Helen Keller who said, there's one thing worse than being blind, and that is having sight, but no vision. Of course, sometimes engagement, empowerment, and involvement can be difficult to achieve. I have heard Jim Conway, Senior Vice President of IHI, describe the push-pull dynamic of that engagement process as making the status quo uncomfortable while making the future attractive. Sentiments echoed by Lucian Leap in 2008 when he said, the time is now. If health and or healthcare are on the table, then the consumer, the public, the patient, the family member must be at the table, and they must be at every table now. That calls on healthcare to embrace patient and family engagement, and it calls on advocates to have the courage to challenge. And I like to think of us as being somewhat like the piece of grit in the oyster, causing sufficient irritation to bring about that precious pearl. And in this case, the pearl is that of healthcare improvement. And then there is the matter of when an adverse event occurs, events which impact severely on patient, family and healthcare staffs. While we cannot give permission for error, we do understand that the practice of medicine is complex, that error does occur. What we are asking in such circumstances is that the healthcare system and the individual practitioners within that system would conduct the business of healthcare in a culture of openness and transparency. In so doing, they prove themselves worthy of the trust placed in them by vulnerable patients and concerned carers. In that regard, it's interesting to consider the results of a survey conducted recently by the Irish Medical Council, which revealed that only over 90% of Irish respondents said they trusted their doctors to tell the truth. I was not at all surprised by that figure because, after all, they are the professionals who hold our lives in their hands and whom we patients do want to hold in high regard. And in the light of those findings, is it not all the more unacceptable whenever that high level of trust is betrayed, especially in the aftermath of an adverse event? And what does constitute an appropriate response? As I see it, disclosure is not about blame. It is not about accepting or apportioning blame. Rather, it is about integrity and being truly professional. It's about learning, preventing recurrence. Families, as I say, do accept that we cannot change the past, but we sincerely hope that our past will be used to inform a better future. In the aftermath of my son's death, there were initial honest and humane reactions from individuals, and I'll always be grateful for that. But in a short space of time, that was replaced by a process of corporate damage limitation. We were faced with defensiveness, closing ranks, lame excuses, and a general mudding of the waters, while we were craving an honest and honourable encounter with the professionals in the system, and answers to our very simple question: how can a young man be admitted to hospital on Thursday and be dead on Sunday? What went wrong? We need to know, we need to understand. Albert Wu describes the period in the immediate aftermath of such an event as the golden moment. The quality and sincerity of the interactions with the bereaved and harmed determines the future course, and whether that journey will be one of healing, learning and improvement, or is condemned to follow the route of confrontation and litigation. And that is why my first meeting with Sir Liam Donaldson in the weeks prior to the launch of the World Alliance was such a revelation for me. He did model a better way. He invited me to describe Kevin's patient journey and our experience. He listened, he heard, he acknowledged the tragedy, he didn't offer excuses, and then he enumerated on his fingertips the number of missed opportunities to save Kevin's life. And he concluded by saying, Margaret, any one of them would have been enough, as he likened Kevin's patient journey to a manifestation of Jim Reason's Swiss cheese model. And I returned home to Ireland, a considerably healed woman, conscious of acknowledgement, of being heard, and of being part of the change process. And what did he do, this man? He validated the patient experience. And then there's the wonderful story from the US of Dr. Rick Van Pelt and Linda Kenny. He was counselled to not make contact, to not apologise nor disclose. The advice from hospital lawyers and colleagues was don't go there. But he saw it as the right thing to do. Sure, they had a difficult first meeting, the doctor and the woman he almost killed. But he says with great relief that on that day, an 800-pound gorilla got off my back. Now that is some image, an 800-pound gorilla on his back 24/7, which he was able to remove by having a decent conversation with another human being. And he now jointly presents with her at conferences, and together they founded the organisation Medically Induced Trauma Support Services, which supports patient, family and clinician when things go wrong. By way of contrast, at a significant point in Kevin's care, crucial blood test results were telephoned to the GP surgery, and they were written on this post-it note by the practice nurse. However, when writing the letter of referral, the GP only included those elements of the blood test results which supported his own diagnosis, omitting a critical calcium reading. He, in effect, filtered the results. We later learned that he had experienced a level of success in diagnosing leptospirosis, which was his differential diagnosis. So here we have an example of how experience can serve you well on the one hand, but can also, in this case, result in tunnel vision. Matters were further complicated by the fact when compiling the file in the hospital, that post-it note was stuck to the back of the letter in an effort that it not be lost, and was not seen until 6 weeks after Kevin's death. So you know the expression, a life hanging on a thread? Well, in this instance, you could say that at that time, Kevin's life was hanging on something as simple as a post-it note. At a meeting in the hospital where he died, the head of department suggested that even if the post-it had been seen by his consultant colleague, it would not have meant anything to him. When questioned, he said it was because it was not written as they would write it. And I asked, are you saying that because it's not written in scientific notation, it would not mean anything to somebody like you? And the man said yes. A proposition that Cal might not mean calcium, SOD might not mean sodium, POT might not mean potassium, and they all in each other's company. It was at that point that I lost faith, as I identified a reluctance to be honest, open and compassionate. I was also uneasy because it seemed to be an attempt to blame the nurse, in that I was to conclude, oh dear, if only that nurse had written it properly. And I did not think that was fair to her. By nature, we're not a litigious family, but you can appreciate how our confidence in any hope of ascertaining the truth through honest dialogue was shattered. And that is why we undertook litigation. Almost 5 years later, a judge of the High Court declared it is very clear to me that Kevin Murphy should not have died. 2 GPs, a private consultant, a hospital consultant, and a hospital, all admitted liability, expressed their regret at Kevin's death, and sympathised with the family. Unfortunately, that was done not in person, but by legal representatives, so the quality of ownership is questioned. Monetary compensation was never an issue for us as a family. The truth is that the sum of money does not exist which would equate to my Kevin, and neither could we imagine any circumstance in which we would derive benefit or pleasure from such money. So consequently, we donated the settlement figure to 2 charities. It is a very real fact that healthcare staffs also bear the burden of error. As patients, we cannot give permission for error, but do accept that, and I accept unreservedly, that no one intended harm to Kevin. And I recall a chance meeting with the young SHO 6 weeks after Kevin's death. He said Kevin was very unlucky. That is all he brought away from the tragedy. That is all the organisation left with him. What a waste of an opportunity for learning and self-growth for that young man. The organisation took the easy way out. And I was angry, but I wasn't angry at him because I actually liked him. And the reason I liked him is because we have a special memory of him. On the afternoon of Kevin's death, as you can appreciate, his friends started to arrive at the hospital, confused and bewildered in a state of shock, sitting on the hospital corridor floor, with their backs to the wall, heads in hands. That young SHO passed by, and what did he do? He stopped. He took off his white coat, the barrier. He rolled it up. He placed it on the ground, and saying nothing, he just sat with them. A most wonderful, spontaneous demonstration of solidarity. He showed himself to be a decent, empathetic, and insightful young man, and he deserved better than a superficial explanation. Chances are that he was being encouraged to get back up on the horse, to return to normality, which of course he would have to do. But there are some horses you need to get a bit of a leg up, and I had no sense that he was getting any part of that support. I also accept that it's a great burden for more senior professionals. To this day, I'm concerned for the registrar, who clearly found the outcome so difficult. He was the man who should have called in senior personnel and didn't, at a crucial time. At a chance encounter, I identified myself as Kevin's mother. He looked shocked, blurted the words, "I didn't think he'd die," and he fled the scene. He was unable to stay in the same space. Clearly, no one had taken care of him either. And we had just come from the man with that nonsense about the post-it note. And I turned to my husband and I said, "Oh my God, they've abandoned us, but they've abandoned him too." Where did he go? Yes, he'd made a mistake, but he did not deserve to be left in that condition. And what have I learned from all this? Well, I have a personal wish list which asks healthcare at corporate and individual levels to observe existing guidelines, best practice and SOPs. Following adverse outcomes, undertake root cause analysis. Communicate effectively and completely with the medical community and with patients. Keep impeccable records and refer constantly to them. Listen to and respect patients and families. Know your personal limitations. Replicate what is good and be constantly vigilant for opportunities to improve. Learn, disseminate the learning. Practice dialogue and collaboration, meaningful engagement with patients and families. Create a coalition of healthcare professionals and patients. And when things go wrong, be honest and open and seize the opportunity to give some meaning to tragedy. Above all, acknowledge error and allow the learning to occur. And do not allow yourself to be seduced by the notion that such things could not possibly happen in your organisation. Sir Liam Donaldson says the 5 most dangerous words are, "It could not happen here." Proper disclosure and dialogue with us as a family would have been far more beneficial to all parties and would have avoided almost 5 years of trauma and uncertainty brought about by the litigation process and the inappropriate responses which drove us down that route. It was also a great pity that the energies of the healthcare system were focused on defending a lawsuit rather than identifying necessary change and implementing improvement measures. So we do have to examine why do essentially decent and professional people often behave in an inhumane way in the wake of adverse events. Sadly, that experience of inhumanity, abandonment, and damage limitation extends not only to patient and family, but also to those individual healthcare professionals who have been involved in the incident. My final area of focus is the patient experience of care, the patient's story. When we in Patients for Patient Safety have come to realise from the feedback we receive that the most effective tool we have for bringing about change is to relate our experiences, tell our stories. Why? Because our stories evoke feeling. In 1967, Vera Keane wrote in the Bulletin of Nurse Midwifery, "Facts do not change feelings, and feelings are what influence behaviours. The accuracy, the clarity with which we absorb information has little effect on us. It is how we feel about the information that determines whether we will use it or not." While the story may be considered as anecdote, it does have an impact. Having presented to a London conference, a Welsh doctor told me he was taking a lot home, pointing first to his head and then to his heart. As WHO safety champions, my colleagues and I experience such reactions on a regular basis. For me, this fits with the motto of the British Medical Association, which says, "With head, with heart, with hand." All 3 elements of practice being essential to the delivery of care that is informed, compassionate, skilled, and above all safe. I'm also convinced that many healthcare professionals do not appreciate how significant they are in our lives. Neither do they always appreciate how privileged they are as individuals, blessed with high-grade intellect, having benefited from superb training. But most importantly, each and every one is gifted with the opportunity to serve humankind on a daily basis. This should be a humbling experience with a potential to allow them live fulfilled and satisfying lives, and should never ever breed any level of arrogance. Interactions with students have reinforced my conviction that as part of their education they must be exposed to and develop for themselves an appreciation of the patient experience. Basic statements such as, "You simple measures save lives," "You ignore at your peril the concerns of a mother," resonate with the student's eagerness to go beyond acquiring knowledge and mastering skills, to appreciating the patient and family perspective, and the importance of preserving the relationship of trust between clinician and patient. That phrase, "You ignore at your peril the concerns of the mother," is critical because, again, I'm convinced that the umbilical cord is never totally severed, and the mum brings a level of insight and sense of something not being just right to the clinical consultation. That maternal gut feeling should not be discounted or dismissed. We have countless examples of tragedy when that happened. the wrong kidney removed from a young child when the concerns of the mother were not appropriately addressed. When students accompany me on my son's patient journey, engage intimately with shortcomings in his care and identify the safety issues which arose, many of them pledge to do better, and in the process they identify with a real person whose patient experience underpins the lessons in the academic course material. And such interactions also facilitate the advancement of sustainable culture change. The value of the patient's story to professional education is also acknowledged by teaching faculties, as evidenced by repeat invitations to engage with their students and messages of appreciation, such as this. I am again trying to make medicine safer for patients and junior doctors, and I believe that you play a key role in that. I think that Kevin's story will once again have the most impact on these young professional men and women before they commence work. As an advocate, I received many patients from students. For example, I was very moved by everything you said, and I will never forget it. I will always speak up, and I will always be honest. Could I, as the mother of a young man who lost his life to medical error, ask anything more of a young person setting out on a career in healthcare? To those who may be experiencing a degree of skepticism, I firstly offer the conclusion of research conducted at the University of British Columbia. Students remember what they learn from patients. The authentic and autonomous patient voice promotes the learning of patient-centered care. I also offer the words of an Indian saying, "Tell me a fact and I'll learn, tell me a truth and I'll believe, tell me a story, and it will live in my heart forever." What is critical is that we preserve the very precious relationship of trust between doctor and patient and initiate the powerful conversation, also known as dialogue. While there is no acceptable level of error will occur, and it is at that time we are challenged to behave with integrity and seize the opportunity to give some meaning to tragedy. In the name of patient safety, the onus is now on each one of us to see that translated firstly into safer care for the raising depth of healthcare, that man in the bed, and secondly, ensuring a real sense of satisfaction for those working in healthcare who have been gifted with the opportunity to serve humankind on a daily basis. Translating aspiration to reality is a challenge. Eric Hollingall's reflection on patient safety says that safety is a core value, not a commodity that can be counted. Safety shows itself only by the events that do not happen. Standards, protocols and guidance, measurement count for naught if they do not impact positively on the patient experience and on the job satisfaction of healthcare workers. It is also very significant that the internationally respected surgeon Atul Gawande has asserted that more than anything, what distinguishes the great from the mediocre is not so much that they fail less, it's that they rescue more. Maybe that's the piece that needs to change, that we concentrate more on rescue and being rescuers. At many points during his patient journey, Kevin so badly needed someone to rescue him, to respond to the deteriorating patient. My sincere wish is that as we go forward, whatever their role in healthcare, all providers will resolve to operate out of that all-important rescue mode. It is, however, equally true that patient and family have a vital role to play, as do patient advocates in the broader scope of healthcare provision. So it is up to healthcare to issue the all-important invitation, and it is up to us to accept the challenge to be critical friends, and I stress that, critical friends in a meaningful collaboration. And to conclude, I would like to say that it is a very real fact that I was present at Kevin's birth. I know every detail of that birth. I was also present when he died. And as his mother, I needed and I deserved to know everything relating to how that came about. But over and above that, it is essential that I be assured that lessons will be learned, that those lessons will be disseminated, all in the hope of preventing recurrence. For as Sir Liam Donaldson says, to err is human, to cover up is unforgivable, but to fail to learn is inexcusable. Thank you.
Well, thank you very much, Margaret. That was Fantastic. And I'd like to go ahead and open it up for questions. And we have our first audience question coming from Egbert Tillings, the CEO of WISH. He says, a word you have used repeatedly is respect. Clearly a key enabler for the patient's voice to be heard. Disrespect, though, is ingrained in the culture of medicine. Dismissive attitudes toward other members of the medical team, toward students, toward administrators, toward patients, have real-world consequences on teamwork, communication, and other core aspects of a safety culture. Ask a nurse, an intern, or a medical student, and they can tell you with pinpoint accuracy which areas of the hospital are toxic to work in and which are not. But what about the patients who have the misfortune to be stuck in one of those toxic areas? It's not just unpalatable, it's unsafe. What best practices have you seen to create a culture of respect?
Unfortunately, I have seen far more practices which demonstrate the disrespect side. We in the Irish Medical Council conducted a survey recently of students and young doctors, and 38%, I think it was either 33 or 38%, reported incidents of bullying. So these are the people who are being formed. So what impact is that going to have going forward? If they're experiencing bullying, is it actually teaching them to bully also? I think one of the softening things that happens is actually bringing patients bringing patients in as teachers. And I think that's where, Egbert, I think that's where where it really has to start. Because patients can actually bring their experiences and make their desire to be treated respectfully. Because no patient should leave an encounter feeling either dismissed, discounted, or diminished in any way. And sadly, that does happen quite a lot. But I think when students sit in front of a patient or a family member, they actually appreciate the impact that has. I think there's a huge amount of a lack of self-awareness among a lot of healthcare professionals. They are not necessarily fully aware of the impact their behaviours have on people. And again, going back to the Medical Council, so many of our complaints relate to issues of communication. They're not, the vast majority aren't about clinical matters. They're about how I've been treated, how, as regards the interpersonal relationship, somebody coming home and saying to themselves when they're back in their own kitchen, what gave him the idea that he could speak to me like that? And I think that's a real sadness.
Absolutely. Well, we have another question here. I know you've had a few quotes throughout your presentation, including the last one that you ended on from Liam Donaldson. He's also been quoted as saying, you wouldn't just decide to forget about recovering the black box after an air crash. So why should it be thought so strange to want to learn from every accident in healthcare? I was just wondering, why do you think there has been such resistance to the idea of admitting to and learning from mistakes in healthcare in particular?
Because I think the people in healthcare do not have the confidence that if they are open and honest and transparent, that they too will be minded during that exercise. They are genuinely afraid of putting their heads above the parapet because they don't see an effective structure in place. If you back out your drive in your car and you bump into the car of the man next door as he's going out as well, and it's your fault, you have no problem in fessing up to that because it's what you do. But healthcare has this huge defensiveness around it. And until such time as it becomes the right thing to do, that it's written into the contract that you are expected to display that integrity, if you like, that true professionalism, because disclosure isn't about blame and should never be about blame. People do have to take responsibility, and actually that's what happened with that registrar that I spoke about. He was so devastated because at a personal level, he had actually taken on board his own individual level of responsibility for what had happened. And I saw that as a really good thing. But he was left there then to struggle with it on his own. And that's the piece that isn't right. People have to be helped and supported in doing the right thing. I was at a conference a couple of years ago, and from the floor I was asked the question about disclosure. This was in Denmark. And I was asked from the floor, Margaret, do you want us to give patients information which they can then use against us? So that's what's wrong. It's the mindset. It's the them and us mindset. We should be actually working together for a more robust and more sound healthcare system, because that's what the healthcare provider wants. That's certainly what the patient wants. So why are we at odds? We should not be at odds. Does that answer it?
Yes, absolutely. And just a quick commentary from Egbert again, just as a follow-up to what you were saying. Regular people who have near misses tell the world about it, like a narrowly averted car crash. We get it off our chests. Doctors don't for fear of derision by colleagues who, if they were honest, all think, there but for the grace of God go I.
Yeah. And you see, the thing is as well, you see, it's the old, you see, we haven't gone beyond the old culture of medical education either, which called for, if you like, infallibility. It called for faultless performance. Now that's an unreal ask of any human being. So if somebody is hardwired to think, I can never make a mistake. Like, I got feedback from an academic one time, and it was after speaking to his students. And he said the usual complimentary things, but he ended up his email with his own first night, if you like, when he was in charge as a young doctor. And his senior was leaving, and the senior said to him, call me if you have a difficulty. And then there was a pause, and the senior added the words, but take it as a sign of weakness if you do. Now that's, to me, is criminal. Like, what does that do to the young doctor who it must be about 2 months ago, I had spoken to students in the RCSI in Dublin. And I left and after I left, and I was out in the street, and I could hear these steps running behind me, and it was one of the students, and he came out and he was breathless, and he said, Mrs. Murphy, I just want to tell you, I promise I'll try and be the best doctor I can. No, comments like from that senior to young idealistic people are absolutely, I don't have the words to describe how I feel about them, because that is destroying the goodness, the innate goodness, the decency, the wish to serve. And to me, that is just untenable. You know?
Yeah, and I think you're kind of getting to the heart of it, that it's a culture change that needs to happen and a bigger culture shift. So I guess the one final question before we let you go, and I know that this is covering a lot of ground, but I was wondering if you had to give a concise, clear takeaway to healthcare leaders. Are there one or two easy wins that all leaders should be looking at in terms of patient safety and shifting that culture? Is there any low-hanging fruit to be had?
I think what they need to do is to bring to the healthcare arena the kind of standards that they have when they're dealing with their families, when they're it's almost like when they come through the front door of the healthcare organisation, they become different people, and that they operate out of different standards. Because when you hear patients saying things like, he said this to me, or he used those words to me, their friends, their family could never imagine them using that kind of, behaving in that way. So it's really hard to understand. And I think what leaders really have to do, leaders have to lead by example. The medium is the message. We have here in Ireland the most magnificent documentation you could ask for, really very high quality documentation on guidance, protocols and what have you. But what really speaks are the actions and how people are. So it's how the mentor is with the patient and with his students, and that permeates then through an organisation. If people, like I said earlier, why do essentially decent and professional people behave in this way? And and it's only as individuals they can get over that hurdle. You can't be forced to be a nice person. You have to choose to be a nice person, and you have to choose to be a decent person. But then all the other people working with you have to have that expectation that you'll be a nice person. And I have found in the different areas that I've worked in, is that if you have an expectation of being respected, and if you have an expectation, 9 times out of 10 that's delivered. So we all have our part to play in it. We all have to, the young student has to go in, of course learning from his mentors, but also having an expectation of his mentors that he will get regard. And the same has to happen with patients as well. You said something about culture. You know, there's some saying, I can't quite remember it, about culture eats whatever strategy for breakfast, something like that. But you see, it's very easy to pin stuff on individual words. I think what we actually have to do is ask people to just be decent people, irrespective of what role they're in, and that when they're leading, they lead through good example. They don't lead through bullying. They don't lead through being aggressive. They lead through actually enhancing the situation that they're working in and making the working environment a place that you're looking forward to come. 38% of students experiencing bullying. So would you even want to go into that environment?
Well, thank you so much, and I feel like that's a perfect place to end. And I think all of us will look at the issue of patient safety with a different narrative in our minds and with our hearts fully engaged. So thank you again for taking the time to share with us today, and thanks to everyone for attending. I know that if you have any follow-up questions, Margaret would certainly be generous enough to answer them via email. Feel free to send any questions to the LHSN team here at lhsn@imperial.ac.uk or to me directly.
And I'd like to ask everybody if they would be good enough to put on, if you like, their rescue cloak and go out and be very responsive to the deteriorating patient, because I think that's an area we can really make a difference in.